Today we're covering field terminations and the documents that guide end-of-life decisions, like DNRs, or do not resuscitate, LA Post, powers of attorney, and living wills. As supervisors, our job is to ensure crews follow protocol, contact medical control when required, and document clearly, because these clauses are clinically complex and legally sensitive. By the end of this chapter, you'll be able to teach the SFD termination pathway, explain which documents are actionable in the field, and standardize documentation and communication so these scenes are handled consistently. Four things drive decisions: obvious death findings, valid medical orders like DNR, LA Post, protocol-based termination rules with medical control involvement, and exceptions like pediatrics, pregnancy, hypothermia, or airway obstruction, where we would default to aggressive care. SFD's non-traumatic algorithm starts with obvious death findings, decomposition, rigor mortis, or dependent avidity. The policy is explicit. This must be confirmed by two SFD personnel. If confirmed, resuscitation is not attempted. For supervisors, the biggest wins here are standardizing communication and documentation. The policy emphasizes that for all traumatic code resuscitation attempts, the time CPR was initiated must be relayed to the emergency department on radio report and again on arrival. If ROSC is obtained and then lost, the trauma team needs the full timeline, initial CPR start time and the time ROSC occurred, and the time CPR restarted, because it does impact downstream decisions, including operative considerations. Next, the Lucas device is not supported for traumatic codes, so if crews default to it, that's a coaching point. If advanced procedures are performed and medical control gives termination orders, the cardiac monitor stays on the patient for at least 2 minutes to account for any delayed rhythm change. Once termination is ordered, keep the patient positioned as if found if possible. If you had to move them to prior to perform efforts, document exactly why. Endotracheal tubes, IVs, monitor electrodes should remain in place. Stop infusions, but don't remove the equipment. Finally, the medical control physician's name, time, and order must be documented clearly in the narrative. The EMS supervisor should be notified so the report can be delivered or faxed per process, and the report should be completed as soon as possible. SFD lists conditions that push you towards resuscitation and transport: pediatrics under 18, pregnancy over 20 weeks, hypothermia, and airway obstruction. These do not terminate categories are in this pathway. Even if things look bleak, protocol drives you toward continued efforts in transport. SFD highlights two big reasons to keep going. If the patient is in persistent or recurrent ventricular fibrillation or ventricular tachycardia, you can continue resuscitative efforts. Also, if the patient responds to aggressive ALS efforts within 20 minutes, you continue. The note to the supervisor is, this reduces premature termination when there is a salvageable rhythm or a meaningful response. The policy also adds a human safeguard. If there's any objection from a healthcare provider, family members, or anyone else on scene to terminating the code, the pathway directs continuing resuscitation and transport. If there are no objections and criteria are met, you contact medical control and discuss termination. Supervisors should coach crews to avoid arguing, use calm explanations, and escalate appropriately. After termination, SFD policy is very specific operationally. All EKG data must be uploaded into the EPCR and CodeStat. When resuscitative efforts cease, leave the monitor attached for at least 2 minutes to ensure medications don't produce a late rhythm change, or the Lazarus effect. The endotracheal tube and IV line should be left in place and documented. The paramedic completes the report as soon as possible, and the EMS supervisor is noted so documentation can be delivered or faxed to the medical facility or the coroner's office. Some of the common pearls for SFD's protocols on this is that time down is unreliable. We don't know unless you actually see it. Pupil exam alone is not enough. Hypothermia, pediatrics, pregnancy greater than 20 weeks can look dead, but we will still resuscitate them. Use judgment when life might exist. Always make sure that you document appropriately. A DNR is about resuscitation and cardiac arrest. It generally means no CPR and no attempted resuscitation and arrest. It is not do not treat. Comfort care, symptom relief, and supportive care still matter. Supervisors should teach crews to verify the patient and validate the document or required identifiers per Louisiana and internal agency policy. Louisiana law describes a DNR identification bracelet that includes the patient's name, date of birth, and the phrase "do not resuscitate" as a valid. In practice, crews still need to follow local policy on what actually constitutes as a valid hospital DNR and how to document verification. This can include paperwork that's signed and witnessed by their physician, but it needs to have a do not resuscitate on it and must be confirmed. If you have any questions, always contact medical control. LA Post is designed to convert goals of care into portable medical orders that follow the patient across multiple settings. LA Post guidance states the form must be signed by a physician and the patient, or the patient's legally recognized representative. Photocopies and faxes of the signed LA Post are valid. Operationally, follow the orders first and then contact the physician as needed. The key teaching point of this slide is that DNRs are narrow. They're focused only on resuscitation during arrest. LA Post, on the other hand, is broad, often specifying CPR status plus levels of medical intervention. The supervisor move is to standardize how crews verify documents and when to call medical control if there's conflict, ambiguity, or familial disagreement. Let's look at these two different things side by side. DNR on the left, LA Post on the right. The primary purpose of a DNR is to address one decision only, whether or not to do CPR, if the patient has no pulse and is not breathing, versus an LA Post that provides comprehensive medical orders for multiple life-sustaining treatments to include feeding tube, endotracheal tube intubation, antibiotics, or CPR. The scope of care of a DNR is limited to CPR, meaning chest compressions for the DNR, defibrillation if you're assisting ventilations during arrest, versus the LA Post that covers multiple areas. When it applies, the DNR only applies during a cardiac or respiratory arrest. The LA Post applies multiple various medical situations. The patient population, DNRs can apply to any patient, and a LA Post is intended for patients with serious disease, advanced frailty, or life-limiting conditions. Now, most of the time, according to Medicare's needs, anyone over the age of 65 intends to have an LA Post for a advanced care planning documentation. The clinical authority of a DNR is limited in clarity and scope, but it is a medical order, versus the LA Post is a formal actionable physician order that clearly guides treatment decisions. The provider's signature of a DNR requires a physician, and an LA Post must be signed by a physician. So if you receive a paperwork that's signed by anyone other than a physician, it is not valid. Power of attorney is frequently misunderstood in the field. A general or durable power of attorney often covers financial or legal decisions depending on the document. A healthcare or medical power of attorney authorizes an agent to make medical decisions if the patient is incapacitated. Louisiana guidance emphasizes that a healthcare power of attorney must be prepared and signed while the person is competent and is not affected later by incapacity. A living will is generally a document stating the patient's treatment wishes, often for end-of-life circumstances. It's different from a POA. A POA or a power of attorney appoints a decision maker. Living will expresses the patient's preferences. In the field, you may not have clean access to documents, so supervisors must teach crews to follow protocol, provide appropriate care, and involve medical control when there's uncertainty. These scenes can turn emotionally intense quickly. Your supervisorial expectations should be role assignment. One person leads the care. One person communicates with the family, which predominantly may be you. One focuses on documentation and logistics. Verify identity and documents. If a conflict persists, especially familial objection, escalate to medical control and follow SFD policy pathways. The goal is patient dignity and a defensible process. This is where supervisors prevent future problems. Patient care reports must clearly show which algorithm branch you were in, what was concerned by two SFD personnel, what exceptions were present or absent, rhythm evidence and medical control details, document objections, and communicate, including post-termination steps, monitor attachment for 2 minutes, and endotracheal tube or IV left in place as required. Final takeaway. Use the SFD algorithm for non-traumatic resuscitations and traumatic resuscitations. Apply exceptions consistently, and involve medical control when the pathway indicates. Treat DNR and LA Post as actionable guidance once verified. Comfort care always remains. POA and living wills matter when the patient lacks capacity. A supervisor's role is standardization, calm scene leadership, and expectations of excellent documentation.